We've sort of been dancing around the maintenance question, so maybe it's time to tackle that directly. And actually, in some of the data that worried people about with the gallium study was that maybe in the bendamustine patients, maybe some increased adverse events were from the maintenance portion of it. There's a couple data sets that suggest that's not correct, but what are your thoughts on maintenance?
Yeah, so I think, the concept of maintenance is really attractive in the disease where if you can get a remission, perhaps you can maintain it for a long period of time. The challenge has been that, with some of the early studies that were done, and probably the PRIMA is the gold standard, where people got, R-based chemotherapy, or so R chemo followed by maintenance rituximab or observation, the initial study showed an improved progression-free survival, but no difference in overall survival. And the caveat to that was around the time that the PRIMA was published, many of us had moved towards bendamustine and rituximab. So the question was, as you already stated, what is the added value of maintenance after bendamustine as opposed to R-CHOP or R-CVP, which had been used in PRIMA? And so I think there's really two data sets that are coming out at this meeting and in publications that inform the concept of maintenance after bendamustine. So one is the BRIGHT trial, which you've published and presented, but after the BRIGHT trial was a comparison of bendamustine rituximab versus R-CHOP or R-CVP, and that is where the study ended according to the initial plan. However, a good portion of patients did receive maintenance afterwards at the discretion of the investigators, and a retrospective look did not find that same type of safety signal. If anything, overall survival was essentially the same and certainly not worse, maybe even just a touch better. So I think in terms of serious toxicity, that study would say that maintenance after bendamustine rituximab is a reasonable option without compromising overall survival. There's also another study that is being done by the Steele group, which did the original BR versus R-CHOP study as well. And in that study, the MAINTAIN trial, they're looking at 2 years versus 4 years. And I think that's where the toxicity of rituximab maintenance beyond 2 years kind of does begin to creep in. And, how much rituximab to give after R chemo, especially after BR, I think remains kind of an open question, but certainly the BRIGHT trial and the MAINTAIN would suggest that there's no significantly increased toxicity.
Josh, how do you approach this with your patients? I mean, I think we've heard from several of the faculty here that we haven't really seen the improvement in overall survival for patients, for a decade or more. I treated most of my patients with maintenance rituximab in the hope that a progression-free survival would ultimately translate into an improvement in overall survival. And disappointingly, we really haven't seen that. But there are patients that it really clearly adds to their treatment and benefit from it. How do you approach this?
Yeah, absolutely. I think, how do you approach it gingerly, because every patient sometimes comes both to their initial therapy and then to the question of maintenance therapy with their a priori beliefs. And we have these patients who are more is better patients, and we have these patients who are less is more patients. Thank God I'm done with am I allowed to say my therapy? Leave me alone and I don't need to be seen so frequently now. And again, without an overall survival benefit, I don't think have any compulsion to give them maintenance therapy. I, like you, had a lot of optimism about it, and it was really approaching common practice some years ago, and I think that decreased somewhat after the early PRIMA data came out. And then we have these patients who they like to come to clinic for therapy or for otherwise. And, this is a little bit like even our bendamustine versus single-agent rituximab, as John was alluding to, where patient preference has an important role. There's not every opportunity for patients to, have some role in managing their care. I think it's empowering that they have some options here. I will say honestly, it's a minority of our patients that do now get rituximab maintenance after our bendamustine. But yeah, that minority is frequently self-driven. They say, I need more therapy.
And, one of the things you brought up was, sort of long-term follow-up and what is the advantage of a PFS versus overall survival finding. And, with the PRIMA showing their very long-term results, I have to be honest and say I don't typically give maintenance for many of my patients for the same reasons that Josh just brought up. But the long-term follow-up of the PRIMA showing that at 10 years, half the patients still did not require another course of therapy after 2 years of maintenance is something that's compelling. Because even if there's not an overall survival advantage, not requiring other therapy for 10 years is something to really consider.
I was also taken with that data, and I think it's an important discussion. There are clearly people that I see that, you know, just the thought of progression, even when I go through and explain, it doesn't really necessarily change their overall survival at all. It's just so hard for them to take, to do anything to, you know, so that they can plan their life better is important.